it's not arthroscopic technique, it's open technique. SL ligament, as described before, that there's a strong connection, U-shaped strong connection between scaphoid and lunate. Then dorsal portion is much stronger than any other part. So key point is the dorsal part. Also, that there is a pivot point during a flexion extension radial ulnar deviation passing through the dorsal part of the cell. So reconstruction of this area is quite important. There is a wide gapping between the SL ligament. Then SL ligament was torn. Then scaphoid flexion. Then trichectomy extends. Then showing a DC deformity. So if once DC deformity occurs, then scaphoid never recovers the normal position. So that this can be very important ligament on that carpal motion. We actually found that there's a Geisler classification, Geisler 1 to 4. Then normally this reconstruction is indicated to a Geisler, some of the Geisler 3, but most of the cases Geisler 4, 2.7 millimeter diameter scope can be drove through the SL interval. But I normally use a 1.9 scope, so it is quite questionable to use a Geisler classification at this moment. Then this video showing that this is a radiocarposcopic view. Then you can find an avulsion of the SL. This is scaphoid, this is lunate. And there is no fibers on the membranous part of the dorsal surface of the SL from the radiocarpal. There may be a remnant here. The mid-carpal arthroscope showing that the gapping of the SL. This is a Geisler 3, so scope can go into this interval but not passing through. Then Gawhale described that his research question, depending on his research question, 5 questions, then he actually made a staging 1 to stage 6. And as PC demonstrates that the stage 3 and stage 4 is a good candidate for the reconstruction of the SL ligament. Then he also mentioned the treatment options for the SL dissociation is for a stage 3 bone ligament bone. Then the stage 4 that he recommended a 3 ligament tenodesis. But normally I also do a bone ligament bone reconstruction in stage 4. If that SL ligament was freshly torn with a disturbed structure, then we just pinned it. Then it worked very well, as PC said, the Wiroc fibrosis technique. Then 4 months after pinning, then there's no wide gapping of the SL. Then also that sometimes we can do a direct repair on the SL ligament. Then Peter was reported a bone, periosteum bone. But he also mentioned that longer follow-up shows that there is a coalition between the scapholunate. Then Rittenberg described that the capital hamate ligament is the same biomechanical identical property on the SL ligament. Yamaguchi and Vigas described the DICD reinforcement on the SL ligament. That is the augmentation reinforcement technique. If the dorsal SL ligament was partially attached to the bone. Then blood tenodesis or Brunel tenodesis can be indicated, but tendon, to my understanding, tendon is not a good candidate, a good at and further that Andrew Chin described that spiral reconstruction. This is very this slide was borrowed by Mark, that he actually reconstructed the 3LT reconstruction. So that in this presentation, we propose a reconstruction method of the SL interosseous ligament using a capital hamate bone ligament bone. So indication of this surgery were static SL instability with more than 4 mm SL gapping, or dynamic SL instability showing that DC deformity. Then this is quite important, that indication that it can be reducible during surgery. Then I use a burger bishop opening the dorsal side of the capsule, then I extend it to distal part to seeing the capital hamate bone ligament bone. Then this is a view of the SL ligament tone. You can see wide gapping between the scaphoidal lunate. Also, you can see capital hamate bone ligament bone here. Then I made a gutter on the dorsal surface of the SL. Then capital hamate bone ligament bone was approximately half was harvested. Then it can be grafted on the dorsal SL ligament, then fixed with a 1 millimeter diameter small titanium screws. And this patient has a membranous part injury, so that I also repaired with suture anchors. This is quite important to know that cartilage of the capital hamate bone ligament bone should be in line on the scaphoidal lunate cartilage. Then in this scenario, that can be avoided any coalition in a long-term follow-up. So that Peter was reported that the coalition of the SL by a bone periosteum bone. So that is natural because the periosteum has a bone making quality. But capital hamate bone ligament bone has a cartilage, so it can prohibit bone formation on the SL gap. Then finally, that we repair using suture anchors. Then this X-ray shows two pins on the one pin in SL and one pin is the scaphocapitate. But now I put two pins on the scaphocapitate, 2 pins on the SL. Since 2008, I operated an 18 wrist. Then majority was male. There's wide gapping of the SL in 60 patients. Then dynamic DC deformity shown in 2 cases. Most of the cases coming from the fall or sports activity. Then we evaluate physiological findings with radiological parameters. Birth was reduced from 70 to 14. Wrist extension is almost the same, but the flexion can be restricted. Then a modified Mayo score obtained 9X and 8 good, 1 fair clinical result. Then return to original sports activity was marvelous, that one patient obtained a bronze medal in the Rio Olympic game in the Paralympic judo. Then the 2 professional boxers can return to the normal professional boxing. Then those 2 patients had with a TFCC region, so that I did shorten the ulna as well. SL gap was reduced from 5.1 millimeter to 2.5 millimeter. Then RL angle was reduced to 10 to 4. So DC also can be corrected. This 32 years old male who has a complete aversion of the SL, then I actually explored the joint, found that there's complete aversion of the SL. Then I reduced, I reconstruction SL ligament with a capital hamate bone ligament bone. Then at the time of KY removal, 8 weeks after surgery, I was a little bit suspicious with the reconstruction. So I checked it, then I found that the complete reconstruction was achieved in this patient. Then 5 years after the surgery, then he obtained an excellent clinical result with an excellent motion with a radial and ulnar deviation, almost normal behavior of the scapholunate. This patient is another patient, 25 years old professional boxer. Then he also has a TFCC injury. So I do shorten the ulna with an open repair of the TFCC. Then I reconstruct an SL ligament 3 months after ulnar shortening. Then I actually reconstruct an SL ligament with a capitol bone, hamate bone. Then 2 months after surgery, it worked very well. However, you can see this screw. Then I checked with a scope 6 months after the surgery. They found that there's a protrusion of the screw. Then I removed it. Then 2 years after reconstruction, he returned to professional boxing. So discussion shows that there are a variety of the treatment options for the SL ligament reconstruction. Then bone ligament bone reconstruction is a good candidate for stage 3 and stage 4 scapholunate dissociation. It obtain an acceptable clinical result, so that this is a promising procedure. So in summary, reconstruction with SL ligament using the capital hamate bone ligament bone was effective to reduce malalignment of the scaphoid and maintain SL gap for static or dynamic SL dissociation. Thank you for your attention.